This is Going Under, Anesthesia Answer with Dr. Brian Schmutzler. I'm Vahid Sadarzadeh. We are brought to you by the Butterfly Network.
All right, I'm going to let you in on something that's completely changed the way I practice. I've been using Butterfly probes for years. It's a portable ultrasound that plugs right into my compatible smartphone or tablet, so I can start scanning at the bedside in seconds. If you've used the older versions, or even if you're new to handheld ultrasound, let me tell you why this new IQ3 is a game changer and really impressive. First off, having an ultrasound that literally fits in my pocket means I can move faster, whether it's vascular access, procedural guidance, or just getting real-time insights from my patients. And the tech inside this tiny device is pretty incredible. Biplane imaging lets me see short and long axis simultaneously, huge for procedural guidance, and honestly, a great tool for learners. The new needle out of plane preset even shifts the scan plane digitally so I can see the needle tip sooner, which makes a real difference when precision matters. And the image quality. Honestly, the IQ3 holds up against some of the high-end cart systems I've used. That's impressive for something this portable. If you're looking for a device that supports your practice, I can't recommend the Butterfly IQ3 enough. And right now, they're running a special offer. You can get $750 off the latest IQ3. Check it out at butterflynetwork.com.
Thank you, Butterfly, for continuing to sponsor this podcast.
That's right.
This episode, we are focusing, because we had such a great reaction to our last episode.
Mm-hmm. And because the new season just came out.
I still haven't seen it.
It's great.
I still haven't seen it.
Well, it didn't
which
just
I want
come out.
to.
It's like they're releasing episodes currently.
Scrubs is also coming out with a new season.
Yeah.
The Pitt is coming out with a new season. And we're going to talk today about what the show gets right about American healthcare, what lessons we're learning from the Pitt, specifically you, what lessons you're learning, if anything. And we're going to talk about AI and moral injury, which you said is a pretty big deal.
Yeah, it's a big deal in
these
medicine.
days.
Yeah.
Well, let's talk about the Pitt. The premise of the show, for people who didn't see our previous
episode. So the Pitt is the premise is that it's minute for minute, hour for hour in an emergency department. And so the first hour is 7 a.m. to 8 a.m. and the episode runs. It's actually like 56.
It's like 24.
Yeah, basically, it's like 24. But it's super accurate. The guys that they used on it, I think they took a little bit from the old ER, but they used like a lot of consultants and stuff, medical consultants and stuff. So it's very realistic. But that's not what I want to talk about today. So, and also I would like to point out, for anybody who has any questions about my number of Facebook and Instagram followers, they're all real. Thank you.
I can attest to that.
And unpaid for.
Can also attest to that.
So anyway, so the Pitt. So the first season, we talked about a few different things, like some of the realism in it and some of the, attacking healthcare workers and all that sort of stuff. So this season, and I'm about an episode and a half behind, so I don't know what the most recent episode showed. And there may be some spoilers, so if you're watching the Pitt and you're not fully caught up, just don't listen, or don't listen to this part. So one of the big things that they talk about, they bring in this new doctor from the VA, and she's big into like electronics and AI and stuff.
Sure.
So she's pushing them all to use an AI system when they dictate. So they talk into a microphone to do their notes, and then the AI is supposed to like take what they say and convert it into a nice note. Well, she's pushing it and pushing it and pushing it and pushing it. And then in the last episode, or the episode before the last one, somebody comes down from the floor and says, your notes were all screwed up on this patient. And so they go and talk to the ER resident who was working on it. And she's like, no, that's not what I said. The AI changed it. So they talk about in that episode how like AI can be a tool, but it's not like the panacea. It's not the thing that's going to fix all of our problems with charting in particular. But anyway, so that brings up the point that, we've talked about, oh no, AI is going to replace doctors. And, Elon Musk says, in 20 years, we won't need surgeons because robots are going to complete all the surgeries. And it's like, we're nowhere near that. And true generative AI is in its infancy. Like, there's not a ton of true generative AI. Now, AI is very good at pattern recognition, which is a lot of what medicine is, but not, high-paced, like fast-paced, high acuity medicine. It's fine if you're looking at an X-ray or something like that for radiology, but I think it's going to be a big problem for this type of stuff, like when you're trying to do something fast-paced.
AI right now, in my estimation and my experience, is a helper. AI is not a replacer.
Yep.
It's a tool,
right,
Almost like if you were using Google.
Right.
Almost like if you were. Now, is it replacing some surgeries or aiding surgeries? Kinda?
Not really.
So, I mean, I don't know. Listen, for people who are like, oh, AI's, I think we've talked about this in the past, like taking jobs or whatever.
Not yet.
No.
Not yet.
Now, will it get to that point?
Maybe. Yeah.
Probably.
Yeah.
Right?
I mean, I think attorneys are, so pathologists, primary care docs, radiologists, and attorneys, I think, are at risk. Because those are all things that you can teach a computer to do, and it's mostly pattern recognition.
But there's no emotion, right? Like,
Yeah, true.
you're not. So, and this is where I get at this. So, for a physician or whatever profession you're in, I'm in the media profession.
Mm-hmm.
I have played around with AI, meaning, okay, AI, make me a video.
Yeah.
You see,
Oh, yeah.
what is it? Sorel, Sora is like the program that uses AI to make videos for pictures
Goofy
or whatever.
videos, yeah, right.
Yeah.
Right, yeah.
So we see the Trump memes all the time. Right. So in my experience with it, you can create a video. You can create a picture. You can create whatever you want. You can't replace the emotion in the video.
Yeah, that's true.
You can't replace the actual, right, like the feeling behind it.
Sure.
So scratch that. Let's take medicine, for example.
Yeah.
You're not going to replace the physician. You're going to aid, right? You can aid in the processes of what it takes.
For the most part. I think, again, there's a couple areas, pathology and radiology in particular. You know, it's really, it's pattern recognition, right? There really isn't a whole lot of art. And again,
but surgeons?
So it'd be hard to replace.
ER?
Hard to replace that.
Anesthesiologist?
Hard to replace, yeah, for sure. But the other thing that's funny, and then we can move on to the next thing that the Pitt's been talking about this season. But the other thing that's funny is, it's two things. So number one, they get to the point where they realize the AI is making mistakes, and then they have to go back and reread and proofread all their notes after the AI
so
does
it's
them.
double the time.
So it's double the work, right? So that's funny. Number two, and we'll get to this in the next one, is that all the computer system goes down. And so once the computer system goes down, you have to go back to paper charting, and so the AI is gone. So that flows very nicely into the cybersecurity issue. So in one episode, and again, spoiler alert, but in one episode, the cybersecurity goes down at multiple hospitals around the Pittsburgh trauma or whatever it's called, the fake hospital in the Pitt. And so they're getting all these patients because their computer systems are down. Well, turns out that they're about to get hacked as well. And so the CEO comes in and says, we're shutting down the entire computer system. And you watch all these like Gen Zers like, oh,
panicking, right? Panicking.
And I'm like, yeah, when I started medical school, even the beginning of residency, like halfway through residency, we still did paper. I had paper charts, paper orders, paper everything. So
I don't think anything's wrong. I still take notes.
Yeah. So anyway, it's funny to listen to them.
Do you take paper notes anymore?
Yeah, I do. Yeah. I don't have any on me right now, but I take paper notes. But anyway, that does bring up the point of cybersecurity, right? So you hear over and over again, there's systems that get hacked and all these Russian hackers that hold them for ransom and all that kind of stuff. So it's interesting. I think cybersecurity is one of the biggest issues in medicine right now.
So there is a worry.
Oh yeah, 100%. Yeah. And a lot of times it's not, they've got these like super high tech defensive systems and everybody's like, preventing anything from getting in. And usually it's something innocuous, like some random person clicks on a link or clicks on a video or something, and then the malware comes in and then they take over the whole system. So it's interesting that the cybersecurity, I don't think we're at a point, unless you can get everybody to not click on anything, we're not at a point where we can prevent cyber attacks. So
what does this mean for digital storage of records? I mean, I think that's been a back and forth issue in medicine for years now is, why the paper trail, why the paper trail, when you can back it up.
Yeah.
Why have we figured out security online for anything else, but we can't do it for medical records?
There is security online for medical records. They get stored, but yeah, it's not bad to have a paper copy. and then to back things up not only on hard drives but on a cloud as well, so that you can access that cloud. Like, let's say you get hacked and then you've got a cloud out,
Okay, this is where it all comes together.
Mm-hmm.
Hard drives are expensive these days.
Yeah, especially to hold as much data as you would need for that.
Data centers are hoarding.
Yeah,
right.
Hard drives.
So I'm experiencing it. 4 terabyte, 8 terabyte hard drives, they're double the price.
Right. Yeah.
Does that make it more so? Like, do you guys as a hospital system or a surgery center, do you look at that and say, okay, the cost of storage has gone up, we in turn raise our prices? You don't do that.
No. We can't, right? Because we're based on our prices have to be based on services, and there's fee schedules. And
does administration look at that?
Probably not. I doubt it. Yeah, and I think we store most of ours. Like, I don't think most hospitals store their patient records unless they're paper on site. I think most have remote hard storage access and then cloud access. So,
all right.
But yeah, so it's interesting that whole thing happens in the episode, and then everybody freaks out, and I'm like, I could paper chart. So anyway, that was kind of an interesting portion of the show, which I think is, and we talked about before, like Change Healthcare got hacked, which was like one of the biggest clearinghouses, and Ascension Health got hacked, which is a Catholic hospital system. So there's a lot of that going on.
Hollywood tends to mythicize these things sometimes.
What do you mean? Mythicize?
I don't know. Like, they tend to over dramatize.
I didn't seem over dramatized.
No, but you think this show in particular
is pretty accurate.
Is very accurate.
Yeah.
What lessons are we learning? What lessons are you learning from this show?
About cybersecurity?
Just about medicine in general.
I mean, I'm not an ER doc, so I'm learning a little bit about how the ER works. Like, we talked on the episode last season about how they use an ultrasound for everything, right? Like, and they even had a butterfly in one of the episodes. So, I mean, that's interesting to me, because I definitely didn't do that when I was in medical school doing emergency medicine. But yeah, I mean, I think it's just, I think if you weren't in medicine, there's a lot of things you look at and be like, wow, I didn't know that. I think if you're in medicine, it just represents a lot of things that could happen. So I would say the one kind of unrealistic portion of the show is that all this stuff happens all in one 12 or 14-hour shift. Like, you're not going to have all this stuff happen in one 12 to 14-hour shift. Like, no matter where you are, even if
it's not going to happen
in Chicago, it's just not going to happen. But I mean, otherwise, what are they going to do? They're going to have 3 hours of the show where everybody's just sitting around doing nothing. Like, that's not going to work. So,
I want to focus in on the next two topics here. Cost and access to care.
Oh, what about is that? Oh yeah. Sorry, yeah. I thought we were going down to the social media. Yeah,
not yet. We'll cover social media.
Yeah, well,
and your real followers.
There's an interesting thing on one of the episodes, but yeah, cost and access to care. So here's the interesting part of things, and I'm pharmaceutical companies. I understand that they're necessary, that they are a business, they need to make money, they do a lot of good things, research and development, but there's a particular part of one of the episodes where a guy gets what's called DKA, diabetic ketoacidosis, because he can't afford his insulin. And so then he goes to the hospital because he gets DKA, and then he can't afford his hospital bills. And so I guess what I wanted to focus on is the fact that some of these medications, including insulin, was super expensive because there was so much research and development to it. But if you look at the history, so insulin's been around for 100 years, right? That we've known about diabetes, how to treat diabetes. We've known about insulin for like 100 years. And I think we should do an episode just on diabetes, like the natural course of diabetes, how you treat it, all that sort of stuff.
Next week.
So what they used to do is they used to take out the pancreases of pigs and isolate the insulin from the pancreas of the pig and then put it into a medication. Right? So that's expensive, time consuming, right? In the mid to late 80s, they figured out a way to just use a bacteria, put a gene in it, get it to replicate, and then you get that, like, basically secretes insulin, and you just take the insulin, right? So I get that the research and development 100 years ago was probably pretty expensive, but there's no reason insulin should be so expensive. Like, it's like $500, $600 a month for something that probably...
Insulin is?
Yeah. That probably cost them, per dose, 1/100th of that or less.
So we are discovering in GLP-1s that it is not a cure-all, but it is bringing blood sugar lower.
It is, and GLP-1s were designed to be a diabetic medication. Yeah, they're a diabetic medication, but they're not insulin, right? So there's two types of diabetes. There's insulin-dependent diabetes and non-insulin-dependent diabetes. If your body still has the ability to make insulin, what these drugs do, like GLP-1s, like SGLT2s, like metformin, they help your body use the insulin you have to get the blood sugar into your muscles, into your...
So if you're type 1...
Well, it's not as clear as type 1, type 2. So now we call it insulin-dependent diabetics and non-insulin-dependent
So
diabetics.
That's where that terminology is shifted.
Correct. Yeah. So it used to be type 1, used to be kids just got insulin-dependent diabetes, type 1 diabetes. And then type 2 diabetes was older people who burned out their pancreas because they ate too much sugar or whatever. Now what's happening is it's so bad that people are turning from type 2 or non-insulin dependent diabetics to insulin dependent diabetics because at some point your pancreas has produced so much insulin that it burns itself out. And there's probably an autoimmune component. So anyway, we'll talk about this. That can be a whole topic in and of itself. But what I'm saying is these pharmaceutical companies that produce insulin produce it very easily, very efficiently, and very inexpensively now. But because it's such a big demand for insulin because so many people are diabetic, they charge a lot for it. So I question. I didn't realize it was $500-$600. Yeah, I question. Again, I'm not a big like government control guy, but I question whether there's some price gouging here. So how do we deal with that? Now that's a whole nother issue. But so that kind of brought up a little bit of issues. And then the other thing is, just the cost of care in general and how, if you don't have insurance, if you're in that middle range where you make enough money to not be at the poverty line to get Medicaid, but you also don't make enough to afford health insurance or your employer doesn't give you health insurance, you can get stuck in this area where you're basically the working poor that has no ability to get insurance. So they brought a lot of that stuff up. I guess my biggest issue is we probably shouldn't be charging $500 per dose of a drug that you discovered 100 years ago.
Right.
That costs $5 to generate now. So anyway, that was my diatribe on that.
Let's talk about social media.
Healthcare and social media.
Here's my favorite thing. Here's my favorite thing and comment that people have for you.
What's that?
Other than, oh, you have fake followers.
Fake followers, yeah.
Good one. Here's the one that really is interesting to me. When people are like, shouldn't you be
working
instead of doing social media, Doc?
Right. Do you say that to people who are out golfing or spending time with their kids or whatever, right? I mean,
let's talk about kind of maybe the building of your platform because
sure.
It's been a few years now.
Yeah, let me relate it back to the Pitt episode, and then I'll talk about my own journey. So, she's actually a medical student in the show, comes in, and one of the patients specifically asks for her, and the resident's like, I mean, I can get her, but why? And so she comes in.
She's calling herself a resident.
No. Yeah. She's an expert. She's calling herself
expert. Yeah.
So she comes in, and the patient's like, "Oh, I watch all your TikTok videos. I want you to do this procedure."
That's funny.
So I mean, I have had people say like, "Hey, I recognize you from TikTok." But anyway, so that's that, and they don't really get much into it except to say like, you've got to be a little bit careful. You can't have patient stuff on there. You can't have identifying information, But yeah, so my own journey, we started the social media platform 4 or 5 years ago. 5 years ago now? 4 or 5 years ago.
Yeah.
Mostly because coming out of COVID, it was really hard to travel. I wanted to teach blocks. And so we started the process of putting a Patreon together and doing all this stuff. And that it's very niche and it didn't really take off. But then had a little bit of luck. We were in New York City, did a video that was trending at the time. We are anesthesiologists. And it got, 4 million views or something. And so from there, I became sort of the self-deprecating, funny anesthesiologist, which is fine. I mean, we got a lot of...
You walked in the hallway and got 10 million views.
Yeah, we got a lot of viewers now. We got a lot of followers and stuff.
But a lot of medical students, too, who follow the page.
Right. And we do some serious stuff. It's not all just jokey stuff. And then we have the podcast that people can listen to as well. So
yeah, so I mean... Listen, when you're at work, you're at work.
Of course.
You're not doing
Right.
You're not using the ER or the surgery room.
Yeah, and we do all this like off hours.
Right.
We do it when patients aren't around. We do it when people aren't around. Like it looks, you guys do my social media team does a great job of making it look realistic, but we do this outside of business hours. So
yeah,
I never worry about that.
You're not there with a patient.
Yeah. Although, except when we have in the past done that, we have gotten their consent. We don't show their face. We don't say their name, right? So we've done some of that, but all
HIPAA compliant.
All compliant. But yeah, so that one issue, that one comment that I got on one of the pages that I have now for some other things I'm doing that said that my followers were fake and purchased. They are not fake and purchased. And that comment more than anything else ticked me off. So anyway, next.
Person who has 900 followers.
Yeah.
Focus on your own.
Probably bought all those.
Yeah, focus on your own people.
So the next issue we wanted to talk about, and this is kind of the final portion that we'll talk about. And there's this idea of moral injury.
I'm curious because I never heard of that before today.
So this is big in medicine, probably has been for the past 5 to 10 years. So we used to talk about burnout, right?
Yeah.
So that's when you're just working too hard. You're not getting kind of what you need out of your practice or whatever, and you feel like you're working too hard and not getting anything out of it, and so you start to burn out. Moral injury is even like kind of the next step. So you're burnt out, but you keep working, and then you lose basically your core values, right? So you no longer come to work and want to help people because you felt like you've been beaten down. And so there's a lot of discussion of how do we prevent this, but one of the biggest pressures that creates that moral injury is lack of being appreciated by patients and by administrators, and then adding additional non-clinical work. Those two things cause the most moral injury. So
non-clinical work means paperwork
or meetings, or being driven by the bottom line, not by patient care. Like there's a lot of things that come from a non-clinical administrator point of view that causes this moral injury. So like some of the things are like being forced to discharge patients early, or to do more. Like for me, you need to do more cases to generate more money because the hospital needs more money. Getting treatments denied by health insurance. And again, I'm no fan of health insurance. This has been very clear for the last however many years. If you know me at all, I'm not a fan of health insurance. Being forced to document things more so than take care of patients, right? It's more important that you make sure the documentation's right so we can get paid than you actually take care of the patient. And then, like I said, all the administrative pressures that come of like, make sure the charting's the right way, the billing's the right way, this, and this, which is not something that we really care that much about as healthcare providers. We care about taking care of patients. So.
How much is burnout, A, and B, depression, a big part of the medical industry?
Yeah, so burnout's huge. I mean, some studies, you can read anywhere from like 40 to 90% of people experience burnout at some point during any year. And the longer you're in practice, the more burnout you have, the less control you have over your practice. So if you're employed by a health system, the more burnout you have, as opposed to being in private practice or owning your own practice. So it's huge. I mean, burnout's huge. In terms of like clinical depression, I think that's a little bit harder to evaluate. I think there's still a stigma, particularly in healthcare, where if you say you're depressed and you go on an antidepressant, that you're concerned that the board is going to look at you or that sort of stuff. So it's probably underdiagnosed in healthcare. But I would say in general, it's probably about the same as the general population.
Is there a stigma to talk about it?
Yeah. Oh yeah.
Yeah.
Yeah. Yep. Especially like suicidality. There's a big stigma about that because if they feel like you're suicidal at any point, they take you out. Like if you're working in, a factory putting together widgets and somebody finds out that you had a suicide attempt, they're not going to not put you back on the line, right? You're going to continue to make widgets. If you're in medicine, they're not going to put you back in, right? So I think there's a huge stigma in that. And then another big issue of that though is that if you are removed from work for whatever reason, that's a lot of financial pressure then, right? Especially for people in medicine who take on hundreds of thousands of dollars in debt. And so if you're early in your career and you haven't paid that back and you're trying to, and then you're not allowed to work anymore. So
have you, okay. So I'm gonna pose this question to you.
Mm-hmm.
Do you find that most doctors, you're gonna laugh at this, but I truly
I'm not gonna laugh. I wouldn't laugh
there
at
is
you.
a reason I'm asking the question. Do you think a lot of the doctors that you have interactions with get into medicine because it's a passion and it's fun? Fun meaning, right? Like you're actually following a lifelong passion and a dream, and it's exciting every day when you wake up and it's like, hey, I'm or is it more, this is what I should be doing?
I think it's a combination. I think anybody who has any knowledge about it's not getting into it to get rich, right? I mean, because there's a lot of ways you can make a lot more money. I think a lot of people get into it for the right reason, but I think you get beat down pretty quickly because medicine's not about taking care of patients anymore. Medicine is about money now.
That's a line.
It is, but I mean, it's the truth, right? When the federal government took over healthcare, which is 1/6 of our GDP, it became all about money, right?
So when was that? Do you think? When was the breaking point?
Probably
90s.
Probably Great Society, the 60s, the 90s. Yeah. So that's when Medicare and Medicaid came about, right? So that's when a lot of the pressures came to reduce the cost of medicine. I think generating revenue in medicine probably came in, like you said, in the 90s when health insurance companies became huge and when private equity started buying into the medical field. So, I think prior to Medicare and Medicaid, prior to the Great Society, physicians or healthcare professionals made the decisions in medicine, and it was more about taking care of patients. Now, there was money in it, right? Mm-hmm. There was still money being generated, but not the way that it is now, where it's basically just like the military industrial complex. There's the medical industrial complex now, and so it's all about extracting money out of the system to give to stakeholders, not about using the money in the system to take care of the patients.
Awesome.
So,
thanks for explaining that.
Yeah. So just one other quick thing. Yeah. So the moral injury thing again. This was not a big portion of the show.
Sure.
But I think they allude to it, and so it's probably good for anyone listening who's in healthcare to talk about the moral injury. How do you address it? So re-anchor to purpose, right? So you want to make sure that when you go into work, you're not saying, "Oh, this is so terrible because I have to document this," blah blah blah. Recalling why you started, right? I want to take care of patients, or I love doing these procedures. Whatever it is that got you into it, you want to re-anchor to that. You have to figure out something to do outside of work that's productive. And so it's interesting. One of the guys who's an ER doc in the Pitt actually does SWAT work. He was in the Army, and does SWAT work as his time off because he loves the adrenaline of it or whatever. For me, it's lifting weights, working out.
Yeah. So you have an outlet outside of the hospital.
Correct. And taking some time off, right? That's the other thing. We've talked about a little bit now that it's a busier time right now. But in general, for the last couple of years, I've been taking Saturdays completely off of doing work. Now I do stuff around the house and I hang out with the family, but I've been taking Saturdays off of doing any work whatsoever. So taking a Sabbath and it's pretty clear that that's helpful to kind of overcome moral injury. The other thing is faith and moral grounding. So, again, I'm a Christian, very openly a Christian, but really, if you read the literature, having any faith or moral grounding that you can go to does help in the moral injury aspect of things. Having peers and people you can talk to, not just like somebody you see in the hallway and wave at, but somebody you can actually confide in. And then finally, having boundaries and saying no. So if the administration comes to you and says, hey, I need you to go from seeing 30 patients a day to 40, you say, no, I'm not going to do that.
Right.
I just can't. I can't see 40 patients a day responsibly.
I just think honesty in what you're doing is huge, but also knowing your limitations, right? I mean, I think it's easy for people who me, maybe some folks out there who are just go all the time, just to put your head down and just be like, I can't take one. Because we know our own limitations.
Right.
But it's also after agreeing with you and having taken days off.
Oh, yeah.
It's almost forcing yourself to.
Oh, yeah. Yeah.
What do I want to do? Come into this office every day.
And fix and get everything done. Right.
Everything done.
Yeah.
I'm going to be behind.
Right.
It's always this, I'm going to be behind stuff. Yeah. But at the end of the day, it's like, Yeah, I gotta just
Yep.
your mental health, your physical, emotional, spiritual health, all are at play and make you better at what you do.
Yeah, absolutely. And whatever that means to you, whatever day of the week it is, even if it's like, okay, I take this afternoon off and this afternoon off, I think there's an argument to be made biblically and even outside of the Bible, just mentally and mental health wise, that you need to take a Sabbath, take some time off. And so, I think
in closing,
I would say, The Pitt, I love it. It's a great show. It's great to watch, but it does bring up a lot of things, particularly for us, those of us in healthcare. And so, it shows chaos, but also shows courage, and it gives some sort of generalized themes they're not overt, but sort of underpinning some of the things that there are some ways that we as healthcare professionals can get better and overcome a lot of this stuff. So I love the show. Everybody should watch The Pitt. I am not paid by The Pitt. I have no connection to The Pitt other than just watching it. But everybody should watch it because it's great.
Me included.
Yeah, so which you haven't done yet.
Which I haven't done yet. Yeah. I will. I'm getting around to it.
Let's do it.
This has been Going Under Anesthesia Answered with Dr. Brian Schmutzler. I am Vahid Sadorzadeh. We're brought to you by the Butterfly Network.
And we'll see you next time.